pathology. So we know your topic for today. This is a squamous cell carcinoma, expanding role of endoscopy in the treatment of esophageal squamous cell cancer. And I just want to ask you, after every 5-10 minutes, if it's possible, just have a stop in your presentation. I will translate in Ukrainian language for our doctors in 2 words, because I have information, maybe not everyone is understanding English very well. So after 5-10 minutes of your part of lecture, I will translate for our colleagues in Ukrainian. Okay? I will just interrupt them. So we pay whole attention for your lecture, and please, we are ready to hear you and to look the presentation which you prepare for us. Please, your time, Professor.
So thank you very much, Vitaly and Sergey and David, for inviting me and us to your meeting. For us, it is a great pleasure to be with you and to discuss the new points with regard to endoscopic diagnosis and treatment of the esophagus at all. So I would like to focus today on the expanding role of endoscopy in the treatment of early esophageal squamous cell cancer. First, I would like to focus on characterization and delineation of early esophageal squamous cell cancer. Then I would like to focus on endoscopic treatment. And because endoscopy is expanding, I also want to focus on the expanding role and indications of endoscopic resection in early esophageal squamous cell cancer. So let me start with the characterization. When we look at the squamous cell epithelium of the esophagus, it is a specific epithelium which has a multi-layer epithelium structure. And this specific structure, compared to the stomach, where you have this typical glands, has the advantage that we can nicely visualize vessels in the mucosa and in the submucosa from the surface. And this is a great advantage for detection and also for prediction of depths of invasion of early squamous cell esophageal cancer. And nowadays, everywhere, we have virtual chromoendoscopy available. We have NBI, BLI, iScan, and we can nicely visualize these vessels in the mucosa and submucosa, as you can see here. So you only need a cap, you need to switch to NBI, and then you need magnification. And here you can nicely appreciate these intrapapillary capillary loops. And you also see nicely in the submucosa these larger vessels. I would stop for a moment.
Okay. Тобто ви пропонуєте, якщо ми бачимо або шукаємо early cancer, ранній рак, іде мова про спомосний рак, використовується скалпачок, використовується MBI режим і magnification збільшення. Це допомагає вам більше детально обстежити і знайти ці ділянки. Це класифікація з приводу луп, тобто судина, це він теж звертає на це увагу, IPCL, і є рекомендація про те, що цей пункт обов'язково повинен бути, якщо ми хочемо виключити цей діагноз. Yeah, we can continue, dear professor.
So the question is, why do we focus so much on the vessels? Because we know when we look at the vessel structures, we can give already information of the depth of a potential tumor infiltration. And today we can magnify more. We can magnify up to 320-fold with the Olympus endocytoscope. This is not necessary in the daily practice, but I only want to show you what is possible today. And when we have a look now at this picture, you may appreciate how the vessels are changing if you have intramucosal cancer and growing to submucosal cancer. So the size of the vessels, the diameter, and also the structure is changing. And these changes are collected in this JES classification because with regard to the prediction of the invasion depths of a superficial squamous cell superficial squamous cell cancer in the esophagus, we have a correlation with the microvessel morphology. And this is here this classification. We have type A and type B. Here you see the regular IBCLs, and when a tumor is growing, you can nicely appreciate we have here larger vessels. Then we get a typical delooping, and if we have infiltration of the submucosa, we have enlarged vessels with also avascular areas.
Окей, тобто, ну, знову ж таки, починають з IPCL класифікації і користуються ендоцитоскопом теж в своїй практиці. Треба під час оцінки судин звернути увагу на сайз, тобто розмір, діаметр і структура. Оце три пункти, які макроскопічно ми можемо оцінювати під час обстеження. І зараз він демонструє іншу класифікацію, Japan Esophageal Society Classification, GES Classification судин, які теж можна, я так розумію, використовувати, якщо є можливість або бажання. Це не вимоги, але він пропонує це теж звернути на це увагу. Yeah.
Okay. So this classification is important because before we start to resect the lesion, we discuss if this lesion is still resectable. And this classification of the Japan Esophageal Society is one point for the decision-making if we still can go for an endoscopic resection of a tumor. When we look now at the sensitivity of this classification, we can admit that if we want to distinguish between mucosal and submucosal cancer, the sensitivity is not that good. It's only 55%. However, when we want to distinguish between regular esophageal mucosa and dysplasia, sensitivity is very high. It's 92%. And also, if we have a deep submucosal invasion, the sensitivity is 90%. So I can tell you this sensitivity is much, much better than endoscopic ultrasound. And nowadays, it is very important to watch a lesion, to try to use the classification. And from there, we can predict the depth of invasion, and then we can decide for endoscopic resection or other treatment.
So, тут була мова йшла з приводу порівняння, якщо використовується збільшенням ендоскопію або необхідність ендоскопічної УЗД, ендосонографію. Тут він більше перевагу дає все ж таки магніфікацію, тобто ви більше інформації можете отримати і більше треба подивитися, більше часу потратити, оцінку макроскопічна, і він дасть більше інформацію, чим ендосонографію в цьому випадку. Тому це була основна мета в цих слайдах. Yeah, we can continue.
So now we come to the delineation, and the point is also maybe nobody everywhere in the Ukraine has these magnification endoscopes. I think for you, the most important point is the detection. And for the detection, we still have the classical chromoendoscopy, which still plays an important role. I know most of you have the white light. And when we want to better detect esophageal cancer, we can use Lubel solution. So if you have a magnification endoscope for the detection, you don't need Lubel solution, but the more bad your quality of the endoscope is, then it is always better to have Lubel solution available, because you will notice the squamous cell cancer first on a small reddish area or maybe larger reddish area in the squamous cell epithelium, and then you have to think of a potential squamous cell cancer, and then you can use the chromoendoscopy to better visualize cancer. And it's very typical, if you have a squamous cell cancer, then you have Lugol unstained areas. So nowadays, we use, as I mentioned, virtual chromoendoscopy, but we can combine both. And still, the classical chromoendoscopy with Lugol plays an important role. I will show you with this picture all the possibilities we have nowadays. So this is the white light. And with the white light, you see here, as I mentioned, these small, subtle reddish changes in the squamous cell epithelium. So if you watch this in your endoscopy, you have to think of a potential squamous cell cancer. And then if you have NBI, you may appreciate here the changes with NBI. You have the positive background coloration, and then you can watch for the changes in the IPCLs. If you have not NBI, you may use Lugol solution, and you can nicely appreciate how this lesion is here delineated by Lugol solution. So we have an unstained area. This is here the typical pink color sign. So after 3 to 5 minutes, it gets pink. And this is very important. Then you can perform here your biopsy. And what we are doing nowadays, it is very important to delineate the lesion for a potential resection. So we still use Lugol, even if we have this MBI image. What we are doing nowadays is that we combine both. So we stain with Lugol, and then we use the different filters. So we first use NBI. And when we have here this area, you will notice this is a metallic color. It is so-called metallic silver sign, and this is typical for early squamous cell cancer, that we have this typical metallic silver sign when we combine Lugol and NBI. And I know in Kiev you also have the latest generation of the X1 technology. When you have this, you can also use this post-processing feature TXI, and TXI everything enhances. So it enhances the structure, the brightness, and the color. And in such a situation, you can nicely appreciate how best you can delineate this early squamous cell cancer if you combine Lugol with TXI.
Okay. Ну, професор не впевнений, що в Україні у всіх є можливість використання ендоскопу високої роздільної здатності з магніфікацією, збільшенням. Тому, якщо є можливість працювати з збільшенням ендоскопа, може бути вам не знадобиться використання Люгола, але якщо немає ендоскоп з збільшенням, то обов'язково користуйтесь Люголем, то він дасть вам більш перевагу, більше візуалізаційний ефект покращується. Демонструють Lugol під час білого світу, Lugol і MBI, ви зараз бачите на екрані TXI. І навіть якщо в MBI є підозріла ділянка, які вже диктує йому, що потрібно брати біопсію, він все ж таки за те, що використовувати Lugol навіть в таких випадках, тому що після використання Lugol він ще більше чітко бачить межі і чітко бачить знахідку, які потрібно радикальним чином лікувати. Тобто він за те, що використовували Lugol в практиці для ідентифікації squamous cell carcinoma.
Let me come now to the endoscopic treatment. So when you look in the literature with regard to endoscopic treatment of early squamous cell cancer, there is radiofrequency ablation discussed. We have the discussion on EMR and on ESD. And I would like to go now a little bit through the studies. So let me start with radiofrequency ablation. So this is a study from Dutch endoscopists with Chinese endoscopists, because the incidence of squamous cell cancer is very high in China. And what they did is they used patients with lesions up to from 3 centimeters, more than 25% of the circumference, Paris classification 0 to B, with low-grade dysplasia, high-grade dysplasia, and mucosal cancer, and then they treated them with radiofrequency ablation. And the conclusion is the results are disastrous, because you can see here already treatment failure initially is already 12.5%. And then when you look at the long-term follow-up, you will notice here in about 60% of these patients, there were already protocol violations. And then in about 20%, we have not only recurrent disease, but we also have progressive disease. And the problem is you perform an ablation, the cancer is not fully removed by the ablation, but then you get new squamous cell epithelium, and beneath the squamous cell epithelium, you still have dysplastic epithelium, and then you have a progressive disease with a submucosal invasion. And the problem, as I mentioned, is that the ablation effect of RFA covers only the epithelium, but is partially insufficient for the eradication of invasive neoplasia. And then we also have the problem in the follow-up. We cannot use Lugol solution anymore, because the absence of unstained lugal areas does not exclude the possibility of subepithelial neoplasia. So radiofrequency ablation cannot be recommended for the treatment of early squamous cell cancer.
Okay. Dear Professor, can you tell me once more USL abbreviation? USL?
Unstained lugal areas.
Unstained lugal areas, if more than 3 centimeters. Okay. Тобто він зараз проводить порівнювання використання РФА, ЕМР або ESD, якщо йде мова про радикальне лікування таких знахідок. І перше, то, що була демонстрована китайське спостереження, це п'ятирічний фоллоуап у пацієнта, когорта пацієнта, який була проведена РФА. Результат цього у нас була не відповідає, тобто фейлер цього лікування РФА при сквамозному раку 12,5% випадків. Результат цього дослідження в тому, що не рекомендується проведення радіочастотної абляції для пацієнтів з сквамосним карциномом, тому що це не дає можливість повноцінно ерадицирувати ділянок, які мають цієї знахідки.
Okay, let me come now to endoscopic mucosal resection. So this is a paper from 2010, but it has a large number of patients. There, the endoscopic mucosal resection was compared with endoscopic submucosal dissection in here 184 and in this group 116 patients. And the result is very interesting. So in the EMR group, there is an en bloc resection rate only of 50%. And in the follow-up, we have a local recurrence of almost 10%. This is relatively high. And also in the long-term follow-up, we have nodal metastasis and also distal metastasis in about 3% of the cases. So this is relatively high. Compared to the EMR, when we look at the ESD group, we have an en bloc resection rate of 100%, and only in one patient there was a local recurrence, and there was no nodal metastasis and also no distant metastasis. So EMR is not very good for squamous cell cancer, and I will show you the reason for this. The reason for this are the submucosal glands. Submucosal glands are specific for the squamous cell epithelium in the esophagus, and these are glands which are connected to the regular squamous cell epithelium, and the surface of these glands also contain the epithelium of the mucosa. So if you have a high-grade dysplasia here in your submucosal gland in this area, you will also have a high-grade dysplasia. And now if you perform an EMR, you don't get out precisely these submucosal glands. So if you don't get it out, you will have a local recurrence in your resected area. And even if you perform ESD, you have to be careful that you don't cut here. These submucosal glands have to be part of the specimen of the ESD of the early squamous cell cancer.
Тут порівняння з приводу EMR і ESD. Перевагу, звичайно, він демонстрував, що мав ESD. Тут ви бачите, en-bloc резекція під час ESD 100% випадків була, і нодул, тобто метастазування в вузлах і дистальне метастазування після ESD 0. Взагалі, тому він дає перевагу ESD, тому що під час EMR тут є так звані субмукозальні железа, які неможливо буде під час резекції повністю прибрати. І під час ESD теж потрібно звернути на це увагу, щоб ці железа повністю були зібрані, тому що є вірогідність про те, що процес далі йде цих субмукозальних желез. Тому він перевагу дає дисекцію порівнянню з резекцією. Якщо йде мова ранній толстоклітинний карцином. Yeah.
Okay, so the endoscopic submucosal resection technique, where we can have the resection en bloc in one piece, is the therapy of choice for early squamous cell cancer. And the technique has been tremendously developed within the last 10 years. And also in Europe, we are now able to perform endoscopic submucosal dissection on a regular basis. And because the technique is expanding, we experience today expanding indications of endoscopic resection. So that means that we are able to resect lesions which we have never tried to resect 10 years ago. And one indication for endoscopic resection is the circumferential extension. So sometimes we have lesions which are growing circumferentially. And nowadays we are able also to resect these lesions by endoscopic submucosal dissection. And I would like to show you an example now.
Professor, you can continue, and then we will summarize.
Okay. This is an example. This is a patient with circular squamous cell epithelium cancer. And now what we are doing, we cut at the distal part and at the proximal part, we do a round cutting. And then we are using a multi-point lifting device. There are several lifting devices. This lifting device has the advantage that we can get lifting at several points. So we are introducing a snare, and then we fix the snare at the side of the specimen, as you can see here. And now we have several possibilities for lifting. We can pull the snare up. So we have better lifting here in this area. And then we can also push the snare. And finally, we can also close the snare. So we can individually decide where we want to have our traction. And now you can nicely appreciate we have a nice traction effect. Here you can nicely appreciate the submucosa. And after injection, we continue here with this endoscopic dissection. And we have to admit that with this technique, we are more safe, and we save also minimum 50% of the time. So this is here the result, circumferential resected early squamous cell cancer of about 5 centimeters. Mm-hmm. And I would also like to show you the final result. This is also important. So histologically, this was a T1B cancer with a superficial infiltration of the submucosa, but it was an R0 resection without lymphovascular invasions. So in this case, we decided for a close follow-up, and this is here the result. 2 years later, there is no stenosis and there is no recurrent cancer.
Follow-up was after 2 years?
After 2 years, yes. But...
Okay. Ну, тут, я думаю, що демонстрував професор все, як він зробив це петлею, кліпсами, як це він називає lifting device. Тобто, я так розумію, таким чином він зробив ліфтинг. І 5-сантиметровий ділянок з плоскоклітинної карциноми, ранньої плоскоклітинної карциноми, він таким методом ерадицирував. І потім ми можемо спитати в кінці follow-up, тобто послідовність наступне обстеження. Зрозуміло. Я думаю, що він через 2 роки пропонував. Так, все. Так, і результат там LVR, він демонстрував, там края чисті були, no metastasis lymph nodes, тобто повноцінна була радикальна резекція, радикальна еразикація цього ділянки. І от тут LVR. То, що ми очікуємо від гістолога, щоб він теж обов'язково це вказав у своєму заключенні.
Okay, the question is now, how far can we go with this circumferential ESD? Because sometimes we have cases not only 2 or 3 centimeters, we have cases with 10 or 12 centimeters. And there are not so much data. There is a first study from Europe. We were also part of this study where we collected these specific cases in 25 international centers. And there were 165 patients. And as you can see here, the on-block resection rate was very high, was almost 100%. We also could achieve an R0 resection in about 70% of the cases. So what these data show is this circumferential ESD is safely possible nowadays. The point is, we definitely will get a stricture, and we are giving the patient cortisone, but the complications of the technique is very low. So there was an intraprocedural perforation in only 4% of the cases, delayed bleeding 0.6. So finally, the overall survival rate is 91%. But the most important finding of the study is that the authors could show that if you have a lesion more than 6.3 centimeters, then you have to expect a difficult to treat stricture. So we experience some patients, they need 3 or 4 dilatations and then everything is fine. And then we have patients who have to come every week for a dilatation. And the point is this, we also have to investigate in the future. And this study shows that if you have a lesion more than 6 centimeters, then you may get a problem with the treatment of the stricture.
Тобто циркулярна дисекція. Так, він демонстрував так зване дослідження, де чітко були переваги з приводу використання цього циркулярної дисекції під час раннього сквамозного раку. Але є ризик про те, що приблизно до 70% випадків ми можемо отримати структуру після цього втручання. Тому якщо лежа, тобто знахідка має розмір більше, ніж 6 см, більше, ніж 63 мм, ризик про те, що структура попрацювати далі, тобто буде дуже агресивний наслідок, як структура, зросте. Тому в цьому випадку іноді нам знадобиться, щоб ми кожен тиждень робили дилатацію, щоб поборотися з цією структурою. Якщо менше, ніж 63 мм, то ризик структура буде, але не так агресивно себе буде вести, як більше, ніж 6 см знахідка характерна. Я думаю, що нічого не буде. Все. Окей.
When we look now in the guidelines, in the Japanese guidelines, if you have a suspected mucosal cancer, then circumferential ESD is recommended up to 5 centimeters. If the lesion is more than 5 centimeters, then surgical resection or chemotherapy has to be considered. And if you have a suspected submucosal invasion already, then the primarily approach should be surgical resection. Because we have to think what comes next if the circumferential ESD is non-curative. In such a case, we have to clearly admit to the patient that we have a problem, that we cannot treat him anymore with chemoradiotherapy. So if you have a patient and you find in your imaging already a suspicious submucosal invasion and you still perform the circumferential ESD, then you have to clearly tell the patient if the resection is non-curative, then the only option is surgery in this patient. And this is very important to discuss upfront with the patient.
Які ризики, які переваги? Ну, єдині структури, він ще раз підчеркують про те, що формування структури – це потенціальний ризик і труднощі провести це циркулярну ендоскопічну дисекцію. Якщо є СМ-інвазія, то потрібно вже звернутися до хірурга і не взятися на цей метод ерадикації. І треба ще певні трайли, дослідження для того, щоб оцінити ефективність і впевненість цього втручання.
Another expanding indication for endoscopic resection is recurrent cancer after definitive radiochemotherapy. And this is here a study from Europe. We were also part of the studies. We could show that we can also treat in Europe such complicated cases. And I would like to show you an example. This is a patient here. He had a T2N1 squamous cell cancer. He got radiochemotherapy, definitive. And after 24 months, he developed again early squamous cell cancer. This is here the underwater endoscopy. And in this patient, we perform an endocytoscopy. Here you can nicely appreciate this is the regular squamous cell epithelium. Here is the cancer. And also with the technique I've shown you before with the multi-point traction technique, we performed an endoscopic submucosal dissection. This is the specimen. And here in this case, we had a superficial submucosal invasion, no lymphovascular invasion. And I would also show you the results after 3 years. So this shows nicely the result. There is no more cancer after the resection, after the salvage ESD of this recurrent cancer after chemotherapy, sorry.
Тобто він спочатку хіміотерапію зробив, так? І потім було втручання. Рецидив, ага. Ну, далі, в принципі, після хіміотерапії.
Контракції було видалено специфічних рецидив, і що логічно було виявлено самодельнуванню лімфоваскулярної і на фото
Тобто це був рецидив на після хіміотерапії.
Схема була досліджена, спочатку хіміотерапія і рецидив.
So, yeah, we can continue.
Okay, so this is a latest study from Japan about this group of patients, and they could show that especially if the patient has no lymphovascular invasion in this salvage ESD specimen, these patients have the best prognosis, and in this study, the 5-year overall survival is about 70%. So finally, I would like to show you our results of endoscopic submucosal dissection of early squamous cell carcinoma, because they are very interesting. So we have about 81 ESDs. Now we have already 70 patients. And as you can see here, the R0 resection rate was 74%. We have also the situation that we have an RX situation. That means that the basal resection was free, but in the lateral area, we had some dysplasia in the specimen that shows that we still have to improve our delineation. And when we look now, 35% of the patients had submucosal cancer already, and 22% had lymphovascular invasion. So that means that we have a lot of patients with an R0 resection, but which are beyond the guidelines. And when we look now at the European and Japanese guidelines in squamous cell cancer, only M2 invasion is accepted. In Europe, also as M1. But if we look now at the curative resection rate of our cases, we have to say, according to the Japanese guidelines, our curative resection rate is only 38%. And with regard to the European guidelines, only 56%. And now the question is, what shall we do with all these cases where the tumor is fully removed, but it is a non-curative resection? The question is what to do. Okay, yes.
Can you show the previous? Yeah, please. Тут власне дані професора, кількість дисекцій, які він зробив, і більшість випадків, звичайно, тут 74%. Це дуже добрий показник для синусу, але тут потрібно ще попрацювати, тому що 18% випадків все ж таки після вічної верифікації. Тут він демонстрував відсотки, коли була субмукозна інвазія і коли була інвазія лімф-інвазія, тобто лімфа і судини. І тут краще зробити, як це демонструвати, щоб цієї похибки не було. І тут ще звичайно, порівнюємо з європейськими даними, теж трошки перевагу має європейські дані ESG. Yes, we continue.
Okay, so this is a question now because we are able to remove this cancer, even it is already submucosal cancer, by endoscopy. We don't want to perform surgery, but what to do now? And I think what we need in the future is a combined assessment of the clinical and pathological prognostic factors. So we can not only look at the pathology, we also have to look at the condition of the patient. And for the squamous cell epithelium, we still don't have a really good scoring system. This is a paper here from Japan. They look also on the non-esophageal cancer-related mortality, and this shows that there are a lot of patients with 3 or 4 high-risk factors, and the 5-year non-esophageal cancer-related mortality is here almost 45%. That means this we also have to take into consideration what to do with the patient, follow-up, chemoradiotherapy or surgery.
Тут потрібно не тільки звернути увагу на те, що нам говорить гістолог. Теж таки потрібно макроскопічно дуже ретельно обстежити. Клінічні і патологічні дані, звичайно, потрібно все сумірувати, але не обов'язково тільки дати відповідальність за гістологічне заключення. Тут він демонструє. Can you show the previous slide, please? Тобто смертність, які пов'язана з ранньою склероклітинною карциномою і не пов'язана. Пов'язана і не пов'язана. І так. Коли це не було пов'язано з скамозним раком. Yes, dear professor, we are listening to you.
Okay, so somehow we are experiencing nowadays a paradigm shift. A suspected submucosal invasion is not a contraindication anymore for a diagnostic endoscopic resection. We are experiencing an increasing rate of non-curative or zero resection, and somehow we need new baseline for clinical decision-making between follow-up, CRT or surgery. And there is a Japanese group with a new concept. So what they did, if you had a cancer up to M3, no lymphovascular invasion, they don't perform any additional treatment. But if you had a submucosal invasion or a lymphovascular invasion in mucosal cancer, where you usually have to treat additionally, they performed a prophylactic chemoradiotherapy, but they reduced the amount of radiation, because the advantage of endoscopic resection is that the tumor is completely removed and we only need to treat the risk of lymph node metastasis. And with this approach, the survival rate after 3 years in these complicated patients was about 90%.
Can you show the previous slide, please, once more? Да, тут перша фраза, що якщо є підозра на SM, invasions, субмукоза, це не є протипоказ для того, щоб ми пропонували пацієнту ендоскопічну резекцію. І далі, the next slide, please. В цьому випадку додаткове лікування це, якщо ви отримали 0,0, тобто додатково по патологічному пункту не потрібно. Якщо є НВ задіяний, тоді і є субмукозal invasion, тоді потрібно додаткове лікування у онкологічному департаменті, але це про те, що це була повна схема. Так, тут треба зробити ендоскопічної реакції, наступним кроком була хірургія. В даному випадку була хірургії дефінітивна хеморадіотерапія, і 90% вдалося уникнути хірургії.
Și ne-au primul rețetă, ne vedem rețetă, că s-a identificat de validez, că cu combinații IgG,
Figura de therapy.
da, deci eu am dus în așa.
Da, și domnul profilacrovate și ne vlad Саме в кінці зараз conclusion, тобто висновки. Зараз ми будемо задавати всі питання, які у вас буде. Будь ласка, задавайте, ми будемо питати. Yes, and conclusion, dear professor.
Okay, so let me conclude. Endoscopic resection plays an increasing role in the treatment of early squamous cell esophageal cancer. Circumferential extension and early recurrence after radiochemotherapy can be treated endoscopically. We need a combined clinical and pathological risk stratification, especially for the cases with non-curative endoscopic resection. And in a non-curative or zero resection, we can perform a selective chemoradiotherapy with lower radiation and less side effects. This seems to be a good option. And for sure, we need more multi-center prospective data collections.
So, thank you for your presentation. Very classic conclusion. And we have a couple of minutes. We know that Giorgi is waiting for us, but our audience have a couple of questions about your presentation. And please, if you have time, we will ask you now, okay?
Okay.
Hello, dear professor. Thank you for your lecture. And we have a question from our audience about the prophylactic chemoradiotherapy. What do you mean compared to the normal chemoradiotherapy?
The point is prophylactic RCT. So you mean in these specific cases after the resection, or what do you mean?
The question is about the dosage, how low it is.
Yes. So if you have still remaining cancer, you have to make a definitive CRT with 50 gray and also a boost for the primary tumor. But if you have removed the cancer by endoscopy, you only need 41 gray for regional lymph nodes, and you don't need this boost for the primary tumor. So this is an advantage that we don't need to treat anymore the local tumor, because this tumor you have resected. And this is a new concept for the future, because we have to admit that chemoradiotherapy also have a lot of side effects.
Okay. Thank you very much.
And one more question, Professor. Maybe it's not always close to your topic, but it's a practical question about the patient with gastrectomy, which was done 10, 12 years ago, and whole the period we have the erosion and the ulcers in the lower part of esophagus. So any suggestions, any method of treatments, because all the gastrointestinal medicines which was suggested for patients is unfortunately not effective. And after 4 or 5 years of treatment, we also see in the lower part of esophagus ulcers, erosions, and very active inflammation. So maybe you will have any suggestions for such kind of patients after gastrectomy?
Yeah, after gastrectomy. Okay. So yeah, the point is that we only sometimes only focused on the acid reflux, but in this case you have biliary reflux, and this is actually very difficult to treat. So we admit to the patients sucralfate, which is a substance which connects with the bile. But the treatment is extremely complicated, and in some cases also patients after esophageal gastrectomy, they have this problem. If you cannot control it, you need to perform a diversion surgery. But for this, you need a very experienced esophageal gastric surgeon. That is a definite problem.
After how many years we can suggest surgery resolve of this problem if we see the non-effective of medical treatment?
The point is, how much suffers the patient. We also have to admit such a surgery is not easy, but if the patient cannot stand the symptoms anymore, then you have to decide for therapy, I think. But anyway, after the previous surgery, you have to wait minimum 2 years until you decide for such a decision of a resurgery.
Nowadays, patients have no symptoms. Symptoms he had after operation approximately 2-3 years. Now, there is a damage of mucosa of esophagus and are non-symptomatic patient. No heartburn, no pain, but we see a lot of damages on the mucosa. So
Yeah.
it's...
I think the symptoms of the patient is almost the most important. If you have ulcerations and no symptoms, don't touch anything surgically. I think you should follow up the patient that he doesn't develop cancer or anything like this, but then I would be very careful with an aggressive surgical treatment.
Thank you. Thank you very much.
Can I ask you about the new APCL classification? One question. We know that if we have A classification, not B1, B2, or B3, it may be normal, it may be inflammation, or it may be low-grade dysplasia. So we don't have any normal sign. What type of tactics we need to choose if we reveal A classification of APCL? Do we need what is tactic? Because it can be not only normal but low-grade dysplasia also.
So I think this is a very good question. You talk about these positive background colorations you see with NBI, and then finally the IPCLs are still normal. So I think if it is a low-grade dysplasia, I think you don't need to worry so much, because cancer also needs time to develop. And I think because can be difficult to treat, and how to treat is also a question. I think you can follow up the patient in 6 months or 12 months. It is not a problem. You will not overlook a deep submucosal cancer. And sometimes it's better to wait how everything develops in the one or in the other direction, and then to decide for an endoscopic resection or not. So a follow-up 6 to 12 months in such a situation is acceptable. I would not perform an ablation of these areas. This, I think, we have to mention very clearly. So in such a case, it is better to follow up the patient than to do anything. And I think you will not miss anything in the follow-up, but it is important that the patient will come to you to the follow-up.
Thank you. Thank you very much.
Last question, Professor. Can the bile reflux cause the Barrett esophagus, or only acid reflux is Barrett?
Can you say again?
Can bile reflux cause Barrett esophagus, or only acid reflux is causing Barrett esophagus?
I think for the squamous cell, the bile reflux and acid reflux doesn't play an important role. That is more for the Barrett's. I think the point is which patient group you have to look more precise. So this is the patients who are smokers or patients with ONT tumors. You have to check the esophagus. So this is still an open question, which patient group we have to preventively perform an endoscopy.
One more question, dear Professor.
Yeah, Professor, thank you for your nice presentation. And the question is about circular and quite circular dissection of squamous cell carcinoma. Do you use any prophylaxis of stenotic changes in esophagus after ESD, in time of ESD? And in which cases you use this prophylaxis? Only with the circular dissection, or if you have maybe semicircular or 80% of circularity of esophagus did you use such prophylactic?
Yeah, thank you for this very important question. I brought this issue up because I know you in the Ukraine also have a lot of endoscopists performing well ESD. And the thing is, we can perform today the circumferential ESD, but we also have to think of the future of the patient with regard to the stenosis. So the problem of the stenosis is still unsolved. So you have several options. Some endoscopists inject some cortisone after the resection immediately. What we are doing is we have a cortisone syrup. Patient drinks the syrup every time for 3 or 4 months. In some patients, I also apply 20 milligram prednisolone orally. Now, at the ESGE days, I heard that you can also, there's a study on Purastat to place Purastat on these resection areas. So we don't have a good concept for the stricture of the stenosis. And I think the most important point, we have to tell this the patient honestly upfront, especially if you have longer resections, more than 6 centimeters. So you were asking me, when do I do a prophylactic treatment? So if I have more than 80% of the circumference, 70 to 80%, I give the patient orally the budesonide syrup. And when I have the circumferential resection, I also apply for minimum 4 weeks prednisolone 20 milligram once per day.
Thank you.
Dear Professor, thank you once more for your time. I'm pleased to having been here with us. And
Yes.
now we will invite your fellow, Giorgi, for presentation. You will stay with us or you will continue to work with your colleagues?
No, I stay with you.
Okay, nice. So a couple of words about Giorgi to our audience. Sure, Michael. Okay. Okay. Колеги, зараз буде феллоу Стефана Зівальда, Георгій з Грузії, який проходив стажування у професора Стефана, і Стефан подав нам ідею, щоб Георгій поділився з нами з досвідом з приводу лікування, діагностики, ведення пацієнтів кислозалежними захворюваннями. Тут йде мова про островах від Баррета. Георгій зараз в Грузії. Giorgi.
Yes, hi. Hello, everyone.
Hi, Giorgi. Nice to hear you. A couple of words about our audience. We have 25 Ukrainian doctors here, gastroenterologists, endoscopists, and pathologists. And we know your topic for today. So, current approach in endoscopic treatment of Barrett early neoplasia. And before you start, Giorgi, just 1 second. То, що ми обговорювали з професором для аудиенції, потім на ланч буде переводити питання, які ви задавали, які потім. Окей. Giorgi, so I know that you don't have Ukrainian language, so I ask you to talk with us in English, and if there is any need, we will translate for your Ukrainian colleague, okay?
Okay, thank you. I would like to start. I'm Giorgi Tvaradze, General Surgeon from Georgia, Tbilisi. And currently I'm Interventional Endoscopy Fellow at Gastrozentrum Hirslanden Zurich. First of all, I would like to thank Vitaly and David for this kind invitation. And today's my topic is endoscopic treatment of early Barrett's neoplasia. So I would like to discuss with you the detection and management of Barrett's neoplasia, what strategy we have for endoscopic therapy, what is the technique of EMR and ESD during this topic. I'm going to mention preferred trial and explain it. Also, I'm going to show you the data from Gastrozentrum Hirslanden. So let me start with 2 consensus. The first thing is when there is no neoplasia, we don't have to treat Barrett esophagus, because individual Barrett esophagus risk to progression into the cancer per year is 0.26%. Also, the second thing is when we have confirmed the neoplasia, eradication of whole Barrett segment should be achieved. This is important to know. On this slide, we can see how we approach or choose a strategy to Barrett's early neoplasia. So from the current guidelines, endoscopically, we curatively treat neoplasia from low-grade dysplasia until superficial submucosal invasion. But the cancer should be well or moderately differentiated and also no lymphovascular invasion. Now let me start with detection, which is crucial for endoscopic treatment and effective treatment. So for the low-grade dysplasia, this is a patient who has low-grade dysplasia. And if we, in regard of imaging, we have the problem. There are no significant changes in mucosal or vascular pattern, even under magnification endoscopy. In this case, maybe some subtle changes, little bit. We have high capillary intensity here, and also the mucosal glands can be smaller, but still everything looks regular and arranged. So I want to say for diagnosis of low-grade dysplasia, the biopsy and the histology is very important. Now we have the next problem for histology of low-grade dysplasia. Because this is very often overdiagnosed, here you can see two milestone papers demonstrating that if the diagnosis of low-grade dysplasia is rechecked by pathologist, expert pathologist, we have downstaging, in this case, 85%, and on second study, it's 73%. Also, if the low-grade dysplasia has been confirmed, rate of progression into the cancer per year, it's 30.5% in this study and 9.1% in this study. So that's why we need expert pathologists to diagnose low-grade dysplasia. Now here comes the second question: does low-grade dysplasia have to be treated? For this, I'm going to show you this very important study. It is a prospective comparative trial from Netherlands. And here is two groups of patients. One group patients have treated with ablation, low-grade dysplasia in here. And second group did not receive any treatment, just followed up. The result of the study is that the group of patients without any treatment, in 25% of them develop high-grade dysplasia or intramucosal cancer within 1 year only. So when we have confirmed low-grade dysplasia, 1/4 of patients will develop high-grade dysplasia or the cancer, and 75% will not. So the conclusion is that the treatment of confirmed low-grade dysplasia has to be considered. And our strategy is to ablate these patients. So we are using a radiofrequency ablation. It is a bipolar electrocoagulation. The only disadvantage of it is that the equipment is very expensive, unfortunately. So let me show you an example. This is a Barrett esophagus, and you can see here the long segment. So we performed a radiofrequency ablation, or RFA, with 360-degree balloon. Usually after first ablation, we use endoscopic cap. You can see cap here, and we remove mucosa. After this, we ablate again. So this is the same patient after 6 months. You can nicely appreciate new squamous cell epithelium in previous Barrett segment. So nowadays you can also use for ablation RFA or cryoablation or APC. So now let me come to how high-grade dysplasia and intramucosal cancer. So high-grade dysplasia and intramucosal cancer should be treated by endoscopic resection because high-grade dysplasia and intramucosal cancer are visible. So the strategy is to resect the visible lesion and to ablate the remaining Barretts. So that's how we do eradication of Barrett esophagus. Now, the detection and delineation is very important and it needs accurate endoscopic assessment. Because unfortunately, many years cancers were ablated and unfortunately still are ablated due to incorrect assessment of the Barrett. So all visible lesions needs endoscopic resection and not the ablation. So when we have visible lesion, we need to do endoscopic resection and not to start with ablation. So now let me show you an example. This is a patient with Barrett. You can see long segment Barrett with low-grade dysplasia in biopsy. They sent this patient to us. But during the endoscopic assessment, and you can also look closely, you can see here is a visible lesion already. So we can see here visible lesion. So we performed endoscopic resection, not the ablation. And actually it was mucosal cancer. This is another example. This patient has Barrett's. Under the white light, it looks normal, nothing suspicious. It's just the Barrett. But if we use NBI mode and zoom endoscopy, we can see that the mucosal glands became smaller and also there is high capillary intensity. And actually also there is a demarcation line. So this all with using endoscopic cap, it's also elevated. So all of this suggests us that it can be invasion into the submucosal. And we perform an endoscopic resection and it shows superficial submucosal cancer. So what I want to say by this is that you have to take time and watch out carefully for changes of the mucosal and vessels. And again, all visible lesions needs endoscopic resection. Now let me talk about the techniques during this. We usually use EMR and ESD. So before you use EMR or ESD, you have to answer several questions. You need to know if this lesion is dysplastic or it's an early cancer. Also, we need to mention the size of visible lesion to choose correct technique. Also, if is possible to do and block resection and if it's necessary. And we always should be careful about if there is sign of deep submucosal invasion. So now let me show you an example. This is Barrett's patient, and here is a visible lesion, 2 centimeters lesion. So what should we do? Should we do EMR or ESD? Today, of course, we choose ESD because we caught up with the ESD techniques. However, if you look at the date, it was done in 2010. So by the time ESD in Europe were not so good, that's why we performed the EMR. We used ligation device duet set for the resection. And I want to say that with adequate overlapping, it's possible to have very good result. And to demonstrate it, please watch the following video. This is a principle of adequate overlapping. Now you can see here the cap is always placed in the previous resection area in order to get all mucosa into the cap. And then we resect it. So this is the principle of adequate overlapping. This is the result after resection. You can see clean area without and no remnant ridges, so it looks perfect. After we did RFA of remaining Barrett's, of course. Now I'm going to show you the same patient after 12 years. And you can see there is a clean scar, no recurrence cancer. So the result is great. What I want to say is that if you do EMR with properly and use overlapping technique during high-grade and mucosal cancer, you can get a very good result. But here is one small problem. You cannot achieve R0 resection. In this case, you will get Rx. It means that vertical margin is negative and horizontal margin is positive. But this is accepted for mucosal cancers. This concept has been proven in this study, European multi-center study with 132 patients. So it shows the effective piecemeal EMR plus RFA with high-grade dysplasia or early cancer. So we can complete eradication of whole neoplasia in 97%, and the recurrence rate only is 4%. But even this 4% we can treat with endoscopically. However, there is another study with EMR, 350 patients, and this study shows that piecemeal resection is an independent risk factor for recurrence. That's why you need to, and we prefer to use ESD in larger lesions today. Also, there is ESGE guidelines, which suggest us to use ESD when we have suspicious submucosal invasion, when the lesion is above 2 centimeters, and when the lesion is located in the scarred or fibrotic areas. Also, there is another point that nowadays we have more complicated cases and lesions. For example, you can see a lesion like this, or this big lesion like this. This is still mucosal cancer, but if you start a resection by EMR, you will definitely mess up the case. So this paper could show nowadays that we are able to treat these complex cases by ESD without significant complications. And also we are in part of this study as well. Now I'm going to show you the next case. So this imaging is done by Olympus X1 processor, and the scope is 1200, and still you can see here the lesion, right? It's elevated. But when we use TXI mode and NBI and zoom, you can see there is loss of mucosal pits and some avascular areas. That suggests us that it is submucosal invasion. But we tested and it had still lifting sign, so it was positive. So we could do ESD. So this is the area after ESD. It looks clean without any perforation. And here you can see the specimen en bloc resection. But on the histology, it showed T1B cancer, and invasion was deep submucosal invasion, 680 micrometer. So, of course, there was no lymphovascular invasion. But what do we do with this patient? from current guidelines, it needs surgery. But because nowadays is a century of organ-preserving medicine, and also current guidelines and limits of curative endoscopic resection are under critical evaluation. And I need to mention this new preferred prospective study, which I will explain. So we put this patient into the preferred study. Now, what is the preferred study? It was demonstrating this year on DDW and ESGE days by oral presentation. So the preferred study is prospective endoscopic follow-up of patient with submucosal esophageal adenocarcinoma. So now I will explain it in more details. So in this study are 19 international centers. Also, we are part of this study. It includes 157 patients, and we follow up these patients 5 years. The primary outcome is 5-year disease-specific survival and overall survival. How this study is done, what is the methods I'm gonna mention. So first, we perform endoscopic resection. It should be R0 resection, and it should be T1B esophageal adenocarcinoma. After resection, we do restaging with upper endoscopy plus AUS plus CT and PET scan. Next, when we confirm there is no lymph node metastasis, we start to talk to the patient, wait for consent, and put this patient into this study. In this study, there is 2 groups, high risk T1B and low risk T1B. In high risk, invasion into the submucosal is 500 micrometer or above 500. And the cancer is poor or undifferentiated. Also, lymphovascular invasion is present. So this is high-risk group. On the other hand, the lower risk group invasion into the submucosal is less than 500 micrometer, and the cancer is well or moderately differentiated. And here, no lymphovascular invasion. So after we resect, we wait 6 weeks and perform CT scan. After CT scan, we do every 3 months upper endoscopy plus AUS. We do like this 2 years, every 3 months follow-up. Then on the 3rd and 4th year, we do every 6 months follow-up. And at least on the 5 years, we do 12 months follow-up. So until now, I'm gonna mention the preliminary outcomes. It is important to see the distant metastasis rate is only 2%, and lymph node metastasis is only 6%, and the recurrence rate is also below 5%. Also, it is important to mention that esophageal adenocarcinoma-related deaths is found in 3%, and the non-esophageal adenocarcinoma-related deaths was found in 6%. So it is very promising study, and we all waiting for its final results. So by now, it showed us that it is lower metastasis rates as reported in a recent endoscopic series. Also, endoscopic resection with strict endoscopic follow-up is valid treatment for T1B patients. Because still the curative treatment such as surgery remains possible in case there is lymph node metastasis or local intraluminal recurrence. Otherwise, majority of patients demonstrating uneventful follow-up. So this is very promising study. So this is our data from Gastrozentrum Hirslanden, and we have from 2008 till today for early Barrett's neoplasia. The number of patients are 425, and from them we did endoscopic resection in 384 patients. You can notice that from 384 patients, 77% was done by using the technique of EMR, and 23% was done by ESD. Also, it is important to mention 200 patients we did endoscopic resection, EMR or ESD, plus RFA. Now, what is important for histology? For histology, you can see in EMR group here, mainly it was high-grade dysplasia, 37%. And there was also 27% of intramucosal cancer. But in the ESD group, you can see high percentage was intramucosal cancer and also submucosal invasion cancers. Also, I need to mention here is lymphovascular invasion 40%. It's higher than EMR, of course, because ESD group of patients were more advanced lesions, and we still could safely resect it. Also, I'm gonna mention that recurrence dysplasia was found only in 2% in EMR, and in ESD group it was 1%. But this was the recurrence dysplasia into remaining Barrett's area. Also, this is a great result here, distant metastasis almost zero. But what about the surgery indication for EMR and ESD? For the results, you can see here for EMR, it was 1.7% for indication of surgery. And for ESD, it was 90% for indication of surgery. But because nowadays there is a prospective data and there is ongoing pre-FAIR study, we put 9% into the pre-FAIR study. And we operated only the 10%. So now what I want to say and what is the take-home message? It is important to remember that accurate endoscopic and histopathological assessment is mandatory in Barrett's patients. Low-grade dysplasia should be ablated, and all visible lesions should be endoscopically resected. Also, EMR or ESD with RFA are effective treatment and effective for eradication of Barrett esophagus. Nowadays, endoscopic treatment is expanding. Diagnostic endoscopic resection should be performed first as long as safely possible. There is a promising studies running, such as was the pre-FAIR study. And for every centers, it is important to have collaboration between endoscopists, pathologists, and surgeons, because it is for patient best outcome for patients. Thank you very much for your kind attention. Thank you.
Giorgi, thank you very much for your presentation. I kindly ask you to stay with us, please, because now we have time